So today we're going to present on the new WHO guidelines that came out as policy updates and rapid communications in the last few months in the lead up to the full guidelines being published in April this year. And these include a number of guidelines on both drug-resistant or rifampicin-resistant TB and HIV co-infection. So today we're going to concentrate specifically on how the latest TB guidelines are relevant for people living with HIV co-infection. So firstly, we'll touch on the new TB Alif-LAM or lateral flow lipoarabinomannan guideline updates. Then go on to discuss the molecular assays guideline updates, the DRTB cascade of care, and the DRTB treatment guideline updates. So firstly, on the TB lateral flow. Lateral flow test is essentially a type of assay whereby both the sample and the reagents flow across the test in order to detect and diagnose someone for the target that is being used on the test. In this particular test, it's for LAM, which is otherwise known as the mouthful of lipoarabinomannan, and it forms part of the cellular wall of mycobacteria and is one of the virulence factors. And it's shared from mycobacteria, or in this case, Mycobacterium tuberculosis, and can be measured in the body. And in this case, these tests measure LAM in urine specifically, which is a very easy sample clinically to measure from people. And there was a policy update in late 2019 from the WHO. You can see on the left-hand side there the cover of that policy update. And this test is specifically used to diagnose active TB in people living with HIV specifically. The current guideline is only applying to the allele-determined TB-LAM antigen test from Abbott because it is currently the only one that is both commercially available and has been assessed by the TB department at the WHO for endorsement for use for diagnosis of TB. And there you can see a picture of it from the Abbott website. And essentially you pipette 60 microliters of urine at the end of the test, and then it flows down, and if there's any LAM, it is detected on the test. There is a second test that is commercially available that is undergoing clinical studies this year and will be assessed by WHO for the guideline development group later in the year. There is a lot of excitement about this test because it is more sensitive. At least the analytical sensitivity has been shown to be higher. And there is a reference there from biobank urine samples. So we will see later this year if the guidelines on the use of LAM testing change in terms of the subgroup of people that can receive testing. And there is a picture from the Lancet paper of the test there. And more exciting is that in the next 2-3 years, we should see even more accurate, more sensitive tests coming out because the Gates Foundation and others are funding and working on new and better LAM tests as well. So what do the current WHO guidelines say for the Alif-LAM test? Firstly, in inpatient settings, so hospitalized patients, WHO strongly recommends using Alif-LAM to assist in the diagnosis of active TB in HIV-positive adults, adolescents, and children. So there is no age restriction. One of the big changes to the recent guidelines is that LAM can be used to screen people living with HIV with signs and symptoms of TB, irrespective of CD4 count. So this is a change to the last guidelines. And this is pulmonary or extrapulmonary TB, and it's a strong recommendation. LAM testing can also be used with advanced HIV disease or those who are seriously ill. Again, a strong recommendation, not dependent on CD4. Finally, LAM testing can be used irrespective of signs and symptoms of TB and with a CD4 count less than 200. Again, a strong recommendation, and this one does require CD4 testing before lamb screening. WHO also suggests using Aleph-Lam to assist in the diagnosis of active TB in HIV-positive adults, adolescents, and children, so again, no age restrictions, in outpatient settings. So these are patients who are not hospitalized. Again, there has been a change to be able to use the LAM test in anyone with signs and symptoms of TB, pulmonary or extrapulmonary, or seriously ill. So this is the same changes within patients, no CD4 testing required. Additionally, irrespective of signs and symptoms of TB, but for outpatients with a CD4 cell count less than 100, both of these conditional recommendations. An important message from these two guidelines is that it is important to remember that Aleph-Lam is a rule-in test for TB. So it is a rule-in test to screen for active TB. Although it is still advised to use a molecular test for detecting rifampicin resistance to screen for multiple drug resistance. So you can and should treat for TB if the person has a LAM positive result. There is no need to wait for a positive expert for confirmation. The expert is done in parallel to assess whether there is drug resistance. Also note that there may not be access to a gene expert instrument or other molecular test, and the person may not be able to produce sputum. So it is vitally important that someone be diagnosed and treated based on a LAM positive result. It is also really important to remember that Aleph-Lam is not a rule-out test. So it cannot rule out active tuberculosis if the person still has signs and symptoms of TB. Even if they are LAM negative, additional testing for TB is needed to finally make a rule-in or rule-out diagnosis. So LAM is a rule-in test, it is not a rule-out test. The final recommendation concerning Aleph-Lam is one actually against the use of LAM to assist in the diagnosis of active TB. And it's a strong recommendation that LAM not be used without assessing TB symptoms, without TB symptoms and unknown CD4 cell count, or without TB symptoms and a CD4 count over 200, and without TB symptoms and with a CD4 count between 100 and 200 conditionally. This is based on the evidence that was reviewed by the guidelines development group during the guidelines development. Why are we wanting countries to take up these LAM guidelines urgently and to implement LAM as far as possible? The main reason is that LAM testing can rapidly identify people living with HIV, with TB most at risk of death. So if you use LAM testing, really it can help to facilitate quicker testing and treatment and reduce mortality from TB. It is easy to do this current test in a very decentralized setting. The sample type is urine, so it's easy to collect. The test is quick, takes 25 minutes. It's simple. You just add urine to the lateral flow test, so it's point of care. And it's quite affordable at $3.50, for example, through the Global Drug Facility procurement. And there's been another number of studies to support this mortality benefit. For example, there was a systematic review and meta-analysis of patients with HIV and TB showing that detecting urinary LAM has increased mortality risk compared to those patients without detectable urinary LAM. There was another study by Lorne et al. Showing that it provides major incremental diagnostic yield with very high specificity when used in combination with sputum testing, has important utility among those without respiratory TB symptoms who are unable, for example, to produce sputum, and rapidly identifies individuals with a poor prognosis. Finally, there was a study by Peter et al. In the Lancet showing that land-guided initiation of anti-TB treatment in HIV-positive inpatients with suspected TB was associated with reduced 8-week mortality, and implementation of LAM testing is likely to offer greatest benefit in hospitals where diagnostic resources are most scarce and when patients present with severe illness, advanced immunosuppression, and an inability to self-expectorate sputum. There was a study that was just published last week based on a survey that was done of the use of LAM in 31 countries that were surveyed, although only 24 countries responded. And the main point of this study is to show that really the use of LAM testing in TB HIV high burden settings is really very low. The survey, I must point out, though, was done based on the prior WHO guidelines, which required testing of a CD4 count being below 100 in order to be eligible to do the LAM testing. So it is based on the older guidelines, which are more restrictive. Nevertheless, the main reasons given for the poor uptake had much less to do with the guidelines and more to do with no budget being allocated for the procurement and implementation of the test. No pilot studies being done in country to evaluate the use of the test locally. The use of the test being in a very restricted population that will have improved now with the expanded recommendations. And also there being confusion about whether it was the TB or HIV program's mandate to implement the test. And really it's about both programs integrating their approach to LAM and being responsible for the use and uptake. I'd also like to highlight this brilliant activist guide by the Treatment Action Group. They just updated it and published it on Friday. And it's a great document for outlining not only the new guidelines, but how you would undergo as activists at community level to build awareness of the importance of LAM testing and how to make sure that the test is implemented in your country and in your local settings. TAG also did a dashboard of countries with high TB burdens of TB and HIV, also to show the poor uptake so far. So of the 30 countries surveyed, only 43% have incorporated LAM testing into national guidelines and only 23% are actually implementing. So guidelines to implementation can also take a long time. And the advice given in the document for communities is that they should demand access to LAM testing by working with governments to incorporate LAM testing into the Global Fund and PEPFAR operational plans. This can be budgeted in both the TB and HIV program budget. So if HIV has a bigger budget, please put it in there. Asking national TB and HIV programs to introduce LAM testing as for WHO guidelines, the latest guidelines, and this should include training of health workers. Ask the manufacturer, which is of this current test, Abbott, and the National Regulatory Authority to register the test in country if this is required to implement it. Generate demand by building awareness in TB HIV affected communities and encouraging donors to support the rollout. And there's a link to the activist guide so that you can get more details. Finally, on the diagnostic side, I just wanted to quickly go through the rapid communication on the updates of the molecular assays. So up until now, the only endorsed test has been the Expert MTB-RIF and Ultra. And so I'm happy to say that an additional test has been added in the last rapid communication, which is the TrueNat, MTB and MTB+. The TrueNat also has an MTB-RIF assay that can be done after the MTB test. So the MTB plus is analogous to the Ultra, which is more sensitive. I just wanted to quickly go through the overall conclusions of that document. So reiterating that evidence reviewed supports continued use of the Expert MTB-RIF and Ultra, as the initial diagnostic test for pulmonary TB in patients of all ages. It also supports use of the expert in diagnostic workup of all patients with extrapulmonary TB and children with TB, especially gastric specimens, nasopharyngeal specimens, and stool specimens. This is a really important update that extrapulmonary specimens and particularly stool in children can now be used on the expert to aid in the diagnosis where there is a pulmonary TB, where there is no sputum able to be expectorated. Both assays also show high accuracy in simultaneous detection of rifampicin resistance, which is a sign of multiple drug resistance, and that additional resistance testing may be needed. The performance also of the TrueNat was comparable with the expert, so it can be used as an alternative to the expert. The TrueNat and MTB Plus assays also show comparable accuracy to TB LAMP, which is an ICANN company test. And data for TrueNat show similar accuracy to the WHO-approved commercial 9-probe assays as well, both genotype MTB-DR Plus and NAPRO NTM and MDR TB. And I now hand over to Dr. Cox to present on further TB cascade of care and their TB guidelines for drugs.
Great, thank you, Terry. And thanks to Terry, Ricardo, and Lucy for allowing me to join the webinar along with Vindy. I'm really pleased to be here today. So Terry gave a really excellent overview of the latest information and guidance on LAM. I thought we would shift gears and talk through on the next few slides how LAM can be incorporated into national policy diagnostic algorithms. And this is specifically for drug-resistant TB, but it can also apply for drug-sensitive TB as well. So the policy document that Terry mentioned previously, at the end of it, it has two algorithms. The first one is here for the inpatient setting, and on the next slide, it shows an algorithm for the outpatient setting. And everything you see here on the algorithm, of course, matches the guidance and the recommendations that Terry just went through. I think what's important anytime a new or newer diagnostic test is made available, that the treatment recommendations and algorithms at country level need to be updated, of course, to specifically reflect the decisions made at country level. And oftentimes this needs to be done both in HIV guidelines, TB guidelines, National Reference Lab guidelines, and hopefully they all speak to each other. And the use of LAM is no different. So this first algorithm is for inpatients, so any aged patient living with HIV who is admitted to hospital. They should be assessed for TB signs and symptoms, whether or not they are seriously ill, which is defined at the bottom there in that peach box. Assessed for advanced HIV disease, so CD4 and viral load testing. And then wherever possible, a chest x-ray is certainly helpful. So I added that in here. And in trying to make it as simple as possible in our thinking, because sometimes these algorithms can get a bit complex. On the left side of the chart there, if a patient is positive for TB signs or symptoms, your decision as to whether or not to do LAM is not CD4 cell count based, as Terry said. And optimally, expert, ultra, and urine LAM should be performed. On the other side, and we'll go through that next, you do have to make some decisions based on the CD4 cell count of the patient if they are asymptomatic or have a high CD4 cell count. So I think what's important at the bottom of the algorithm here is when to decide to treat a patient. And if they are positive for symptoms or seriously ill, you can start treatment, as Terry emphasized, based either on a positive LAM result, a positive expert result, or both. And similar to smear, LAM doesn't tell us anything about whether the patient is infected with drug-sensitive or drug-resistant tuberculosis. So there may on occasion need to be some decisions made as to whether to empirically treat for drug-resistant TB if the patient has a positive LAM, but you have no genotypic result to inform you about drug resistance. But starting the patient on treatment early while you're doing those further investigations has certainly proved to save lives. If you don't have a LAM result or an expert result, either unavailable or negative, this box here where it says clinical management, it's very important to remember that TB is not ruled out based on a LAM test or a negative expert test if you have a high clinical index of suspicion for TB. And at that point, more testing should be done. So smear, culture, phenotypic DST, and perhaps line probe assay. Then on the right side, for patients who are asymptomatic or have higher CD4 cell counts above 200, for those less than 200, you may perform the LAM as recommended now. If LAM is positive, it's always recommended to perform expert, again, to tell you whether the patient has rifampicin resistance or not. And then the patient should be treated for a positive result, either LAM and or expert. And then lastly, for all patients coming into hospital who are seriously ill with low CD4 cell counts, we should always be remembering, if we have ruled out TB, to assess for other opportunistic infections and supplying ART, bacterial prophylaxis, and TB preventative therapy if they are eligible. So this is the second algorithm available in the policy update. It's very similar to the last algorithm for inpatients. This is the clinic outpatient setting. What again I think is important to highlight here is if the patient is hospitalized and you have collected a LAM and it's positive, or perhaps you're still waiting, you should collect other specimens to send for additional testing, such as expert, LPA, and culture, and try to collect those specimens prior to starting treatment. The only change on this algorithm is the differentiation between CD4 cell counts of 100 to 200. Per WHO guidelines, if they are an outpatient, you can perform LAM on a patient with a CD4 cell count of 100. What I would suggest is don't use that as the absolute cutoff. If someone is quite worrisome for you and their CD4 cell count is maybe 110, you may decide to go ahead and perform a LAM test. So again, reiterating the key messages for the use of LAM. It is not a rule out test. If it's negative, but you're quite worried, you should definitely not stop there, and you should pursue additional testing to confirm your suspicion of tuberculosis. I do think, and I was chatting to Terry about this, calling LAM a screening test might be causing some misunderstandings. If it's a positive LAM, we can think of it as the diagnostic test needed to initiate someone on TB treatment. Okay, and then now I'll shift gears and I would like to go through the drug-resistant tuberculosis policy updates. First, just to remind ourselves what the definitions are that I'll be using. So as we know, drug-sensitive TB is still sensitive to the first-line drugs rifampicin and isoniazid. Multi-drug resistant tuberculosis, they've now developed resistance to both. Pre-XDR, they have both MDR plus resistance to either a fluoroquinolone, like levofloxacin or moxifloxacin, or one of the injectable agents, amikacin, kanamycin, or kapramycin, of which only amikacin is recommended now. And then XDR, unfortunately, they are resistant to all 4 drug classes. So it's been a busy time. I think we can all agree in the past 4 or 5 years in the field of drug-resistant tuberculosis. It's been very exciting, and I think has motivated us to become more nimble in our technical assistance and our guideline revisions, both at WHO level, as you can see here, and at country level as well. And I won't go all the way back, of course, until 1996, when the first guidelines came out for programmatic management of drug-resistant tuberculosis. But as you can see from the circled area here, there has been a lot of activity in terms of updated guidance for the management of drug-resistant TB for adults, for children, using the new agents, the drugs bedaquiline and delamanid. And then most recently, there was a consolidated treatment guidelines in 2019 and a further rapid communication that was just released. So let's just briefly go through the shifts in guidance. I think it will help you understand how the drug regimens for drug-resistant TB are rapidly evolving and for the better in terms of reduction in toxicities and improvement in efficacy. So before 2016, we were relying on the 2011 update of the PMDT guidelines for drug-resistant TB. Before that time, there was no recommendation for treatment shortening, and the regimen in use, you may have heard, was called the conventional regimen, and it was built on the basis of using an injectable agent, a quinolone, ethionamide or prothionamide, cycloserine, and pyrazinamide. And that was quite standard in a majority of countries that had DRTB programs developing in those years. Treatment duration was at least 20 months and usually up to 24 months. And bedaquiline and delamanid only became recommended in 2012 and 2014, respectively, really to be used for quinolone resistance or the need to construct an effective regimen, which couldn't be done with the drugs I had mentioned at the beginning. So the groups of TB drugs are listed there on the right from the 2011 update, with injectables prioritized first and then fluoroquinolones second, and so on. And then lastly, you can see that was the composition with a slight variety from country to country of that so-called conventional regimen. So in 2016, based on available evidence and emerging evidence, the WHO provided a guideline update, and it's there with the red cover. That was the first time, based on results from observational cohorts and one emerging randomized control trial, that a shorter treatment regimen could be used for essentially uncomplicated multi-drug resistant TB. And it's a 9 to 11 month standardized 7-drug regimen. For those patients who were not eligible, perhaps they had severe disease or they had fluoroquinolone resistance, a longer regimen was still recommended based on updated groupings that you'll see there on the right. So at that time, the fluoroquinolones became Group A, the injectable agents Group B, the other core agents were Group C, and for the first time, bedaquiline and delamanid entered in to the drug groupings in level D2. Treatment duration was still long, at least 20 months, and bedaquiline and delamanid, the newest agents that we have for drug-resistant TB, along with protamanid, were only to be used if an effective 5-drug regimen could not be constructed from groups A, B, and C. For the first time in the 2016 guideline, the advice to avoid injectable agents in children was recommended, and delamanid became available down to the age of 6. So After 2016, countries were starting to deal with several different drug regimens. The first listed there is the one I described as the standardized shorter regimen with the injectable agent for anywhere from 9 to 11 months. And then the longer regimen there with 8 months of an intensive phase and 12 months of a continuation phase, with the option to substitute bedaquiline or delamanid if there was toxicity or resistance to either the quinolone or the injectable agent. Then at the end of 2012, the pre-final draft of new consolidated guidelines was published, and then it was finalized and distributed in March of 2019. That guideline update continued to recommend the use of the shorter regimen, which is the standardized 7-drug regimen for MDR-TB. But at that point, it was recommended that amikacin be used as the injectable agent of choice. This was due to a large meta-analysis that was done that showed that kanamycin and capreomycin actually showed lower rates of efficacy and higher rates of mortality. So they were recommended not to be used any longer for the treatment of drug-resistant TB. The drug groupings again shifted, and they're listed there on the right. And as you can see, Group A now includes medicines from different drug classes. So it's no longer that all the quinolones are grouped together or all the injectables are grouped together and so on. And it was strongly recommended that countries move towards all oral treatment regimens using all 3 drugs from Group A that you see listed there, and then including the 2 from Group B as, if possible, and then adding in Group C drugs if needed. So in other words, a vast majority of the patients diagnosed with either rifampicin resistant or multi-drug resistant TB should receive a quinolone, either levofloxacin or moxifloxacin, bedaquiline, linezolid, clofazimine, and then cycloserine and other Group C agents if they are necessary. Treatment duration was starting to be recommended as a little bit shorter at a duration of 18 to 20 months, depending on when they culture converted. And pediatrics, the recommendations for bedaquiline was lowered to the age of 6, and for delamanid was lowered to the age of 3. So at this point, countries have started transitioning to these guideline updates and have started to have to keep track, I think, carefully of several different regimens they may potentially be transitioning to within their own country. Again, there's at the top, the standardized shorter regimen with the injectable, which was now strongly recommended that the injectable that be used is amikacin. In the middle there is a suggested shorter all oral regimen that can be done through operational research. And then the longer regimen there, which is slightly shorter at 18 months, with using those Group A drugs, bedaquiline, levofloxacin, and linezolid. So just to shift gears before I come back to the final guidance updates from WHO, or the most recent that have been released, just to touch upon drug-resistant TB, HIV co-infection. So all people living with HIV who contract TB are considered to have advanced HIV, and they are at a high risk of mortality. Several studies have clearly shown this is especially a dangerous time if they are not on antiretrovirals. Either they're ART naive or they have been lost from treatment and are not currently on ART. Both the shorter and longer regimens that I've been describing should be given to people with HIV, and the same decisions as to whether they can receive the shorter or longer regimen should be based on their drug susceptibility testing. For instance, if they are fluoroquinolone resistant or not, as well as their risk factors like prior drug exposure. People living with HIV may need to have their ART adjusted because bedaquiline should not be given with efavirenz. Efavirenz reduces the levels of bedaquiline in the blood and thus could reduce efficacy. So every effort should be made not to use the two drugs together. Patients with rifampicin-resistant TB should be prioritized to receive dolutegravir. There's no drug-drug interactions between bedaquiline and dolutegravir. Other options can be lopinavir, ritonavir, or nevirapine, depending on whether they need to be switched from first to second line ART and what's available and recommended in national treatment guidelines. We know that zidovudine causes toxicity to the bone marrow, most notably anemia, and that's a common adverse event of persons receiving linezolid, which is also a group A drug. So if they are on both drugs, FBC should be monitored closely, or perhaps AZT can be switched for another NRTI. And we should always be testing patients who are newly diagnosed with rifampicin-resistant TB with a CD4 cell count and a viral load at initiation and every 6 monthly to see if they are responsive to treatment and have an undetectable viral load. And then some last points on DRTB HIV co-infection. If patients are not yet on ART, there's been no recent changes in the guidance from WHO as to when to initiate HIV treatment after starting rifampicin-resistant TB therapy. For those patients we're quite worried about with CD4 cell counts of 50 or less, ART should be started within 2 weeks. At the other end of the spectrum, if patients have CNS involvement, TB, meningitis, ART should be started at 4 to 8 weeks post-TB treatment, given the risk of intracranial iris and its sequelae. We should never forget to provide cotrimoxazole therapy or Bactrim, and that can be given regardless of the CD4 count. We should be always identifying other comorbidities and opportunistic infections by doing CRAG and putting patients on fluconazole if necessary, for instance. And then I think it's quite important that we recognize the patient support strategies for patients who are co-infected are equally as important as the clinical decision-making and regimen design choices that we're making to support them at a very difficult time. I put this in just as an example of a country guideline. This is specifically from South Africa about the potential recommendations that could be included in national guidelines. These are from the rifampicin-resistant TB guidelines in South Africa. And it's a table with proposed suggestions for adjusting ART regimens for patients who are started on rifampicin-resistant TB. I won't go through that in detail, but I think it's a really nice example of the decision-making strategies to adjust ART for patients who are being treated for rifampicin-resistant TB. So how are we doing as a TB community in transitioning countries to all oral treatment regimens? The WHO's Civil Society Task Force met in June last year, and they put a challenge forward to us, to everyone in every country, to say that by World TB Day 2020, WHO and civil society is calling for all countries to have transitioned to fully oral treatment regimens. In other words, injectable-free treatment regimens. And just to remind ourselves, that's 1 month away, which is not too far any longer since June of 2019. So after the WHO guidelines came out in March of 2019, they it was clear that there was further emerging data on the use of bedaquiline and delamanid in extension, meaning more than 6 months, or combination use of using the two newer drugs together, and some new information on using bedaquiline in pregnancy. And lastly, is it possible to use an all-oral regimen for a shorter duration of 9 to 12 months? And this WHO issued a public call for individual patient data based on those criteria. They added the data that they received to a much larger individual patient data set that they had used for the March 2019 guidelines, which you can see is quite a high number of patients, and then reviewed it at a guideline development group meeting in November of last year. And by December, a second rapid communication for DRTB had been released to reflect the decisions and communications from that GDG meeting held in November. They will also come out with final updated guidelines in probably Q2 of this year. The data that was looked at, as I've alluded to, was a large database of about 4,000 individuals who had been treated with a shorter all-oral bedaquiline-based regimen in South Africa in the years preceding the call for data. They also reviewed the NICS TB trial data, which had about 100 patient records of patients with XDR or treatment-intolerant MDR, who were treated with a short 3-drug regimen of bedaquiline, pretomanid, and a higher dose of linezolid. And then they took also observational cohort data from the NTB study and from both partners and national TB programs globally. So when they analyzed the results and have listed below the specific regimen that's shorter and fully oral with bedaquiline, which was being used in South Africa at the time the call for data was used, you can see it's similar to the standardized injectable-based regimen, but with a substitution of bedaquiline there to alleviate the injectable use. So when they compared it to standardized WHO 16 regimen with the injectable agent, they saw significantly better treatment success rates and a considerable reduction in loss to follow-up. And this was a population in South Africa that included a high rate of co-infection with HIV of 71%. So based on those analysis of those results, they did recommend that the all-oral bedaquiline-based shorter regimen could be implemented programmatically. The second main finding that came out of the rapid communication was recommendations on the use of the BPAL regimen. That was the one I just mentioned that was studied in the NICS study. It showed high rates of treatment success for XDR and in South Africa, which is where the trial was done, very high rates of favorable outcomes. There are some study limitations, which did lead WHO to recommend that BPAL be used only under operational research conditions with careful monitoring and informed consent. So in summary from that rapid communications, for the first time, we now, as a TB community, have a shorter, fully oral treatment regimen recommended for patients with MDR-TB. If they have severe disease or an exposure to second-line drugs or significant resistance, they would still need to go on a fully oral, longer regimen. If countries do want to pursue other modifications to a shorter all-oral bedaquiline-based regimen, they can do so under operational research conditions. And this might be especially promising or interesting to undertake in countries that have a lot of resistance to other drugs in that South Africa regimen I just described, say with pyrazinamide, ethambutol, INH, and the quinolones. And then the final, or the most recent WHO guidelines that incorporate further recommendations about, say, bedaquiline use in pregnancy or extension of bedaquiline, as I mentioned, will be released hopefully by the end of the second quarter of this year. And then I think just to give you a glimpse into the future, there are several ongoing trials. As you can see, for drug-resistant TB, it's really an exciting time to be in the field. They are all short or shorter, anywhere from say 6 to 12 months. They all include, for the most part, the group A drugs, bedaquiline, aquinolone, and linezolid, and they're using different combinations of group B and group C drugs. So I think if we had this webinar even in 2 or 3 years' time, our thinking about MDR treatment regimens will be completely shifted from how we're thinking about it now. But how are we doing after that call by WHO's Civil Society Task Force in a survey that was conducted just before the Union TB conference last year? There was very few of the 30 high-burden TB countries that were initiating a majority of their patients on fully oral regimens. Now, it's good to know that since September, there's been many further countries that have transitioned to all oral treatment regimens. But I think it's up to us to really advocate as civil society and as the TB community to rapidly transition away from injectable use for the treatment of MDR TB. I won't go through these in detail, but Terry and I wanted to include these in the presentation just to give you a snapshot of an idea of what LAM research priorities are. The list of these priorities are also at the end of the policy document that we've referred to during this presentation. And a lot of the research priorities that include HIV co-infection are listed there in red. So in summary, first for LAM, and I'm speaking, I think, on behalf of Terry and myself, it's, I think if there's one message to take home with regards to LAM, it's essential that we have it widely available if we are to budge treatment mortality rates. I think many of us are convinced it's the single most important intervention we can take to shift our treatment outcomes, specifically mortality reduction. A positive LAM should prompt for TB treatment initiation while doing additional tests. We do need to also make every effort that expert is widely available at country level as the parallel testing that should be done with LAM. And I think, can increase our diagnostic yield, especially in critically ill patients, reduce mortality via quicker diagnosis and treatment. For TB and HIV co-infection, we have long recognized that TB is the leading cause of death for HIV. We are all one community and need to ensure that we treat both infections well to reduce mortality. All of our patients, nearly all of them, can be treated with oral regimens, either shorter or longer, depending on their resistance pattern, whether or not they have severe involvement of their TB disease, or if they have exposure history to second-line drugs. The drug-drug interactions and overlapping toxicities are manageable, but do require close clinical management and strong patient support. And I think it's a very exciting time in multiple fields, but specifically for drug-resistant TB, the regimens are improving 6 monthly